morning, good afternoon, good evening. Thank you very much for the kind introduction. Okay, as for AeHIN hour tonight, we for Malaysia will be presenting on Malaysia on Fire. There will be two parts of the presentation. One will be presented by me. So I will talk about the EMR project in Malaysia, which focus on health information exchange, which converts to the HL7 FHIR standards. And the second part will be presented by my colleagues, Dr. Azrin, which is talk more on the FHIR implementation in the HIE platform. Okay, before I proceed with the EMR project in Malaysia, let me introduce first what is the landscape of the Malaysia digital health. So in our 5 Malaysia plan, which is now we are already at the 12 Malaysia plans within the year 2021 to 2025. So it is said that digital will be as the game changer for the health sector. So the theme here is revitalizing the healthcare system in ensuring a healthy and productive people, whereby healthcare services will be redesigned through a collaborative between public and private sectors as well as civil society organization, where healthcare services will be digitalized to accelerate the delivery. In Malaysia, we have something what we call as National EMR Electronic Medical Record Initiative, which is a nationwide EMR implementation in the Ministry of Health facilities, which is both the hospitals and the clinics. The aim of this National EMR Initiative is basically to establish what we call as a National Health Information Exchange Platform, which is the ultimate goal is to have a lifetime health record. If we look at Malaysia Health Vision, basically we aim to have a nation of a healthy individuals, healthy families, and healthy communities. So therefore, in order to achieve this vision, the goals of the EMR initiative is for care coordination and continuity of the care for our people. We must have a clinical, operational, and financial efficiency. Of course, it should improve the quality and the health outcomes. Also, it must be data-driven, and of course, to give a better experience for our patient or the customer to the EMR itself. So the aim and the outcome of this National EMR initiative is to have an integrated healthcare delivery system towards a healthy Malaysia. In order to implement this National EMR initiative, Ministry of Health itself has come up what we call as a digitalization strategic plan, which is the objective of the strategic plan is to implement electronic medical record initiative to drive an integrated health information system towards a lifetime health record to achieve a well-being of the people. The timeline of this strategic plan is started in January 2021, which we already embarked on it, and it hopes to end by December 2025. In order to achieve the EMR initiative, this strategic plan targeted to be implemented in 2 phases, which is the phase 1, which we already embarked, is to come up with a EMR system at hospitals, health clinics, and dental clinics, which is piloted in a state in Negeri Sembilan, which is this all EMR system in the hospital, health clinic, and dental clinics will be integrated under one health information exchange, and also on top of that, we also come up with what we call as a virtual consultation platform as well. This phase 1 is aimed to finish in December 2024, which in the strategic plan, which is 5 years, we would like to move to the phase 2, where we will use the impact study of the phase 1 as a starting point for the initial phase of the National EMR project, meaning that we are going to use the phase 1 impact study, in order to roll out for the EMR project nationwide. That will be for the phase 2. How that we want to materialize the initiative. So as we can see here, this is the action plan for the EMR initiative. The objective of the EMR itself is to establish what we call is a model of a backbone system in Malaysia, which consists of person care, population health, information sharing platform, and also a virtual consulting platform, is to achieve the lifetime health record to improve the people's welfare. So in this 5 year, we target in the phase 1, which is already started for 4 years, we would like to implement what we call is an electronic medical record implementation project in hospitals and clinics of the Ministry of Health in Negeri Sembilan, which is the scope is the expansion of the person care and the population health system, which is in MOH. For the hospital, we already have the system what we call as HIS at KKM, and for the clinics, we have the TPCOCs. To all the MOH facilities in Negeri Sembilan, and also we would like to enhance the functions of the HIS and CIS system, which is these two systems will be integrated through a development of the information sharing platform. And on top of this listed 7 hospitals, 42 health clinics, and 11 dental clinics, it will be integrated with another 32 clinics, which is already have a system. And last but not least, under this phase 1, we would like also to offer something what we call it an application as a virtual consultation platform, which is called as a virtual clinic, which is consists of virtual clinic, online appointment system, and also some e-payment gateway. So the impact study of this phase 1 project will then now use for a nationwide scale up of the model backbone that we want to achieve. As an illustration, this is the state of Negeri Sembilan, which consists of 7 districts. So these 7 districts, we would like to roll out the HIS at KKM, which is the system for the hospital, and the TPCOCs, which is the system for the clinic, to 7 hospitals, 42 health clinics, and 11 dental clinics. So when the expansion and the enhancement of these two systems also will be integrated later with the existing with 37 existing clinics who already have a TPCOC system. So in total, in our pilot project in Negeri Sembilan, there will be 97 health facilities involved under this EMR project. This is another illustration to show where how is this EMR project looks like. So the middle box, which is with the dotted line, that is the information exchange platform. Okay, it will receive information data from the what we call the source system, which is come from the clinics, which is the TPCOCs, and the hospital, the HIS SKKM, and also the virtual clinic. So all the data, the relevant and important health data will be stored and kept and exchanged at the health information HIE system, and can be used by other repository in Ministry of Health. Example like the data warehouse or other external system which is used by the administrators, researchers, or even the policymakers to come up with a better plan for the population health. This is just to show the business architecture of the EMR project as what is now and what it's going to be in the future. I'm so sorry, this slide is in Bahasa, but never mind, I'll try to explain every layer. So the first layer basically is who can access in the EMR project itself. So we can see here there's people itself, the healthcare provider, and there may be the health managers, the facilities, both the public and the private, and also the third party in the system. Let's say in this example is the funder. That is the first layer. The second layer is how the EMR project um, can be accessed. So either is using the mobile, wearables, portals, or even come physical at the counter in the facilities, we can have the access to EMR, emails, and also all the other hardwares. Okay. The third layer is basically is the delivery of the EMR, is basically is the electronic health platform itself, the health information system, and also here the example that we give here is the unified communication channels. Okay, then the fourth layer is basically the function of the EMR project. The most important one is basically is the function for clinical service and support service for the health. Next is the function is for the um, engagement or empowerment of the patient, citizen, or the caregiver in the EMR project, in the EMR system itself. And also we have here the function for the researchers and the policymakers. Okay. The fifth layer is basically is the HIE platform itself. As we can see here, all these green boxes is basically all the system that interact with the HIE, which is it have three portals here. It's a management portal, provider portal, and also patient person portal. And the last layer is basically all the visions that governs the EMR initiative. Of course, all these five layers, which use a standard, which is in this case we are using the HL7 FHIR standards, and also comply with the all the digital and cyber security. This is another diagram to show the overarching concept of the HIE ecosystem within the EMR project. Okay, as we can see here, the HIE platform actually comprise of what we call is here is application programming interface, which is the API. We are using the FHIR. So all these boxes below here, the yellow and red boxes is all the source system that supply the information to the HIE, and all the information actually kept at the HIE platform at the what we call here is at the clinical data repository and also non-clinical data repository. So it will be used at the management portal, provider portal, and also can be used at the patient portal, and also it supplies to the another layer at the data warehouse and also analytical. I think this overarching concept will be further explained by my colleagues, Dr. Azrin, in the part 2 later. This is the overall logical architecture of the EMR project. Basically the HIE in our country. So as we can see now that where relevant, this is the standard HL7 FHIR that we are using. And for the LHR system, we basically have four main components, which is the management portal for the dashboard and also analytic. We also have the provider portal, which is being used by the healthcare provider to key in the information and also to exchange. And also we have the patient portal and also mobile app to be viewed by the people or the person. So all these three portals is under the framework of what we call it is the Cloud Application Development Framework, which is owned by the Ministry of Health itself. That is my overview and introduction on the EMR project in Malaysia. The next part will be, I pass the session to the second part, which is presented by Dr. Azrin.
Thank you, Dr. Zarina. My name is Azrin, and I am the CEO of MPH Nexus. Um, and our company has been entrusted and engaged by Ministry of Health to support and develop the health information exchange, which is the backbone of EMR project that MOH is undertaking currently in one of the states in Malaysia. All right. So the part which I'm going to present, following up from Dr. Zarina's presentation, is pretty much on the implementation of FHIR in the EMR initiative, how we did it, what entails in terms of the processes involved, and I'm going to start with the important part of this FHIR implementation, which is we need to understand the business case, the aspiration of our government in Malaysia in terms of improving the health status and transformation of health outcome in the country. That's the first and foremost important elements of FHIR implementation. And then the second part, I will share a bit on the HIE solution landscape, which already been explained roughly by Dr. Zarina. And then I will introduce a bit on the cloud application development platform, and following that, I will explain on the FHIR adoption and implementation. I have only 10 slides, not too technical, but I do have with me my subordinates and my colleagues in my team who are very technical in this FHIR implementation. And if there are any queries and questions, they will be able to help me to answer your questions. Okay, one thing important in any HIE or any standard implementation such as FHIR is for us to understand the business case. What are we trying to support? And if you look at this diagram over here, this is my illustration on what the government of Malaysia, in particular Ministry of Health, wanted to do in envisioning and empowering the health delivery situation in the country. So if you can see, the center of the business case lie in the person itself. Person is individual. It can be any patient, anybody, and every person has a profile, their lifestyle, ethnicity, age, so on and so forth. And a person may have risks, health risks, different kind of health risks, and with the element of external factors and from risk profile of the person, we can assess the risk and we can stratify the risk of the population. And from the population risk stratification, then we can do population health intervention. And when we look at the risk itself, we can actually further deep dive into a personalized care of that individual. Either we want to maintain, if they're okay, if they are well, then we want them to maintain their wellness. If they are ill, then we want them to manage their illness, where they will go into care delivery, break the four walls of healthcare facility, either primary care, secondary care, tertiary care, or different kind of institution, and hopefully they will receive a good clinical outcome from the care delivery process, and this will improve the quality of care, the reduced mortality, improving daily value for money, and rakyat satisfaction is basically a public satisfaction on the service. So this is the business case and how it correlate to each other. And if we want to have a more efficient and effective delivery of service, then it is best to digitalize some of these components. For example, in the risk assessment, people have been talking about personal health record, and in the care delivery process in the clinics and hospital, we are providing EMR, which hopefully can make the hospital and clinics more efficient and effective. But all this implementation in silos. That's where in Malaysia we are doing this project called Health Information Exchange, to make sure that all information from different healthcare facilities, even information that can be shared with the patient, are exchanged through this platform. because we know in healthcare settings, if you can see in this diagram, information are pretty much shared across, by different components of services. So once all the facilities EMR are able to exchange information through this HIE platform, then we can actually put that information into a repository and produce a lifetime health record. And with all this clinical outcome, if all these are fully digitalized, then we can actually collect the data and do analysis and produce dashboard and whatnot, which can be important, to further intervention of the health situation or any population health intervention. So, so if you look at the entire landscape of this business case, so there are three major components. Number one here, basically related to a person himself or herself, and over here we hope in the project that we are doing, the person can be engaged and empowered to take care of their own health proactively. They can do online health risk assessment, and from there they can be given some sort of action plan or care plan on what need to be done if they need to go and see doctors in the clinic to take care of their health risks. Then they will have to go to the nearest clinic within their area. So that's where we provide what we call a person portal and also mobile apps as part of the project. The second part is the healthcare providers portion, where you have all this hospital information system and clinic EMR and whatnot. So as part of the project, we are providing the health information exchange so that information can be shared across facility, and we are also providing what we call a provider portal for those facilities without any system, so they can have access to the records of the patient digitally. And this is where, between healthcare facilities, we have two use cases over here. One is continuity of care, where whenever a person moves from one clinic to another clinic or to another hospital, so clinical information related to the patient can be shared across. So the next doctors in line will be able to view those information and can make an informed decision on the patient. And the other use case is care coordination. Sometimes a facility may not have specific procedures or medical equipment. For example, a clinic may not have a CT scan, but the family medicine physician may want to do a CT scan on the patient, which is available in another hospital. So HIE platform, along with this EMR, able to manage the order messages across facilities, so that information can travel digitally and service can be delivered accordingly. So this is what we call a care coordination. So all this run through HIE platform. And the other use case is analytics. With all the data available in the repositories, then we can do analytics, and this can be important to facilitate decision making and for the government to do necessary health intervention. So based on those business case and the use cases that I've mentioned, then we design the solution landscape to support those initiatives. Dr. Zarina presented a bit more technical version, so this is a bit more simplified version of the diagram on the entire landscape of the HIE and the EMR. So you can see at the first layer here, we have a different source systems, we call it. So different hospital information system, clinic system, this is pharmacy, this is blood bank system, and so on and so forth. So the list of the source system can grow as we expand from the system from state to state. And then we also have a person where they can have access to their records, either through a personal HIR record, mobile, or person portal. So, so data from the source system can be exchanged through health information exchange platform. So we are using FHIR servers over here to exchange the information, so that so all source system must comply to the standard, and the standard that we are using is HL7 FHIR. So they need to prepare their payload to confirm to the FHIR resource that we have identified, sent to the HIE platform, the FHIR server, and from there, some of the information, some of the data will be kept in clinical data repositories or in the non-clinical data repositories for those data which is non-compliant to FHIR structure. And from there, we can produce dashboard and analytics. So you can see over here, number one, this architecture will be able to support continuity of care. If a patient goes from one clinic to another hospital, then they will be able to see the historical record of the patient clinically. And each facility over here can share their services through care coordination use cases by leveraging on HIE as well. And the person at home will be able to see and view their records captured by all different source systems by calling data from HIE servers. And if you notice, we have this person portal and provider portal. These are one of the modules, one of the components that we have in this HIE platform to enable healthcare providers to view information if they don't have access to any system at their facility, and the person at home will be able to access to their records as well, you know, from anywhere, from mobile or from web browsers. And we have we've developed those components by leveraging on existing cloud platform. So we have this cloud application development platform that we developed for Ministry of Health. Initially for the blood bank information system, this is actually a cloud-based platform where we have components like ID management, middleware for system integration, multi-tenant, the different menu sets specifically for healthcare usage, so on and so forth. So initially we developed this for blood bank information system that used by Ministry of Health Malaysia, and during the pandemic we quickly helped MOH to come up to develop a crisis preparedness response system during COVID-19. The system was developed in an agile and very fast manner. Within a month, MOH Malaysia were able to collect data pertaining to COVID. And then moving forward, when we involved in this EMR HIE project, where we have to develop this provider portal, person portal, and mobile apps, we quickly develop all these portals and mobile apps using the same platform. We started this project in December last year, and within less than 6 months, we are able to actually develop all this portal. Of course, this portal, you know, what we are going to deliver very soon is very fundamental and basic, and it will be further enhanced as we go along. And in terms of the FHIR server, we adopt Smile CDR that was initially based on Happy FHIR platform. And if you can see over here, the external FHIR clients are basically the different source system that send the payload to the FHIR server that we configured in the cloud platform. And we also have this FHIR resource that we constrain from the base FHIR resource from HL7 to be used for Malaysian context. And of course, we have these clinical data repositories over here. And at the same time, we also provide all these different portals, and the portals will send the payload using the same architecture. So in terms of the adoption process, first and foremost, we have to understand the business case, like what we did. And then from there, we look at the use cases and come up with the different workflows. From workflows, we know what kind of information required. And from each information, we further drill down into different set of data. And from there, we identify which FHIR resource that can support the entire workflows. So these are the steps that we did. So we call that a FHIR profiling. And for example, continuity of care. So we identify which FHIR resources are suitable to support continuity of care, and we pretty much took the entire FHIR resource that we wanted, and we had sessions with the users and the stakeholders, walk through the FHIR resource line by line, I mean those important ones, and then we decide whether we want to accept it or we want to constrain it. And then we look into the need of having any extension, if any, and then for every vocabulary that we want to use, we define the code system. If there's if there are any local code system, then we will adopt that, and then we define what are the value set for each code system, and eventually we'll produce the FHIR resource, which we call FHIR resource MyCore for Malaysian use in the country. And eventually we produce what we call a Malaysia implementation guide. Currently we have about 29 FHIR profile, and we believe as we go along, this FHIR profile will keep on increasing from time to time. Let me jump into our implementation guide so that you can have a look at how it looks like. So I'll stop this presentation for a while, and let's move into, so this is the implementation guide that we have developed for Ministry of Health, and we are using Simplifier tools for this. So you can see the background, the objective of FHIR implementation guide for Malaysia, and over here these are the list of resource profiles that we have, from security to documents to organization, workflow, and whatnot. So we've got 29 FHIR resources here that we adopt from HL7. And I give example of one of the FHIR resource, which is the patient resource. We call it patient MyCore resource, and you can see the snapshot of the structure, that the model that we use from FHIR, the constraint that we have put into this FHIR resource, the mandatory requirement, the slice, the extension, and most important, the vocabulary. So for example, we have ethnicity. So whoever wants to comply to this FHIR implementation in the country will have to look into this implementation guide. And here is an example of one of the code system. So if I open ethnic for patient, and you can see these are the different value set for ethnicity, and this is actually a local code system that we use for Malaysia, and this code system were produced by Ministry of Health. There are different type of code system that we can actually use and adopt. For example, law in code or SNOMED City, and different other code system that have to be decided by the local stakeholders. So there are also extension. So we have got quite a number of extension that we have to put in. So I'm not going to go into detail of that. So I'm going to go back to the PowerPoint slide to continue my presentation. So those are the processes, and I've shown you the example of our Malaysia implementation guide. Currently we have published it. and waiting for MOH to expose it to to all the industry players in the country. So this is my last slide. Lesson learned so far. Throughout the implementation of HIE, we are still implementing it. There are 4 stages of implementation until end of next year. So far, it has been quite good. We have learned a lot. But one thing that we learned is to work on the data quality. We realized that when we implement this project, some areas, either clinical or non-clinical, we still a bit lacking in terms of information model, either clinical information model or non-clinical information model. We don't have specific rules. We don't have, in particular, vocabulary binding and relationship. We haven't decided whether these sets of data need to comply to the certain code system or not. Of course, we have got some which we have MOH have decided, like diagnosis. We use ICD-11, for instance. But there are certain data elements which we have not yet decided. So moving forward, I think any country who wants to implement such a project need to sit down and work out what are the different terminology binding that you want to use in your implementation. So like in Malaysia, we move along, we as we go, we decide on which code system that we want to use, and we have a consensus, we agree, and we implement. And many a time we just simply adopt FHIR resource model, and we discuss in great detail of the structure of that FHIR resource. We decide with all the stakeholders. So in a way, we need to have a FHIR committee who understand FHIR structure itself and the different code system that is available throughout the world. Currently, we are working very closely with Dr. Fazila's team and Dr. Zarina's team on identifying, different code system and value sets that we plan to use in the project. And at the same time, we train those involved in the project team on FHIR as we go, so that they have a better understanding, and especially when we want to make a decision. And number 3, there is a need to invest on FHIR knowledge capital. So like in my team, we do identify a few people who must be knowledgeable in FHIR. Otherwise, it is going to be difficult for you to do mapping. There are situations where you have a complete information model, and then what we need to do is to map to the right FHIR resource. And there are situations where we don't have a comprehensive information model, where we need to adopt a FHIR resource, if you may, and to do this, you need to have that knowledge. And lastly, what important is to understand the end game, the business case, the vision that we are trying to achieve, because implementation of any system is, it's not just providing a tool for healthcare providers or for patients to use. And we are looking at implementation of such project, especially EMR and HIE, to be part of the health intervention, to be able to change the landscape of healthcare, to make it better, to make it, to be able to improve outcome and having a, value-based care, not just for the healthcare fraternity, but for the public at large. So with that, I end my presentation. I would be happy to answer any question, if any.
Thank you so much, Dr. Zarina and Dr. Ashrin, for the presentation. So we have quite a number of questions in the chat box, but some of them are being answered. So I'm pulling out the questions that are not being answered yet. So one question from Dr. Alvin is, what strategy do you use to empower the health facilities to exchange data, carrot or stick, or both?
Can I answer that question?
Yeah.
Yeah. Okay. Actually, this project is a national project. So for a lot of buy-in and change management has to be done. So it's not carrot or stick, but it's just that you have to exchange data. So it's a requirement. When the state of Negeri Sembilan was chosen, so we had to do a lot of buy-in with the state health department and so forth, with all the hospitals and clinic. So I think when we are talking about any ICT project, EMR or EHR, it is the people aspect I think is very important. So that's how it's done. But right now it's only confined to Ministry of Health. So it's easy for us to say you must do it. But I think once you have other private sector or GPs come into the picture, then we have to start thinking of incentive for data exchange.
Thank you, Dr. Fazila.
I think
So-
someone is, I think, okay, go ahead.
Yeah, there's another question about 29 FHIR profile. Do you mean 26 FHIR resources from Muhammad Ayas?
Azrin, maybe you can answer that.
Can you repeat that question again?
Yeah, it's 29 FHIR profile. Do you mean 26 FHIR resources?
The 29 FHIR profile may comprise of more than 29 FHIR resources. So the profile, each profile may contain 2 or 3 resources. So it depends.
So, hello, sir.
Yep.
Yeah. So the profile here we mean when you are making profile. So what profile? I mean, individual profile representing what? Either individual health information system. Are you creating one profile for one health information system?
No. It is not like that. So it is based on, for example, we have discharge summary as a one use case when you want to share information across facility, right? So we use what we call a composition profile from HL7. So that's one profile. But in the composition profile, we have to use a patient resource profile, and maybe a questionnaire profile at the same time. So we structure this together as part of the entire FHIR profiling for that particular use case.
I mean, so you mean individual profile is for individual use case, business use case?
Yes.
Okay, sir. Thank you, sir.
All right.
Okay, thank you. Another question from Shalati. How can a physician see a patient's medical history via web-based or integrated with HIS?
So the question is, how can a doctor,
Physician, yeah, a
physician
doctor.
see a medical history from a web-based?
Yeah, or integrated with HIS from web-based.
Integrated with HIS. Okay. I can answer that in relation to our HIE project. As part of our HIE project, we have this provider portal. Provider portal is actually a web-based application where you can actually open up from the web browser. So in this provider portal, the data that you can visualize in the provider portal coming from clinical data repositories, and data that kept in the clinical data repositories actually came from different source system, different EMR available in the hospital or clinic. So for a physician, if they want to see the past medical record of a patient, then they can actually log in into this provider portal and actually view the clinical records or past historical record of that individual from different facilities in this manner. Does that answer the question?
Yep. And sir, regarding the FHIR server, did you create your own FHIR server, or you created the online which is available, free server which is available?
We are doing it in collaboration with Smart CDR. So the Smart CDR is actually It's an extension from the FHIR, if you know.
Yeah, I know. Yeah, that's
Yeah.
why I'm
Yes. So
asking.
basically the base is actually FHIR. So yeah. So
So
we did.
you mean you are using the FHIR server, which is available free online, right?
Yeah. But we use the paid version, which is called Smart CDR. I mean, but the base is actually FHIR. You can also
Actually,
use.
I'm asking about implementation point of view. So does it possible that we can create our own file server from the FHIR server?
Yes, that is possible.
Yeah, I mean, online it is available. I mean, or it is license based. You need to pay something like that.
If it is FHIR, it is actually free for you to set up your servers.
I mean, I can set my own server on my own system.
Right. But you need to have your own, cloud platform that you want to host that FHIR.
Okay, sir.
Right.
Thank you so much.
Okay, we have one new question coming in. How do you manage the different coding system? Do you use a specialized terminology service?
Since we are using this Smile CDR, which is based on FHIR, so one of the component that they provide to us is a terminology server. So we can actually upload, a different kind of. I mean, there are available terminology mapping there, like SNOMED City, Line Code, ICD 10CM, and a few more. But at the same time, we have to create our own terminology server, to put in our local code system in place. So when we receive payload from the different source system, then we can check against those terminology servers on the data that they send.
Yeah. Hello.
But but for some of the thing we have standardized, for example, diagnosis has to be ICD-10, or then moving forward ICD-11. For procedure is right now ICD-9 CM. We might be moving to ECHI. And then for drugs, it's Malaysian drug codes. And for lab is line codes. And for oncology is the oncology codes. Yeah, we adapt the international standards, but some is just localized to Malaysian.
Yeah, actually, sir, my question is that when you are mapping that when you are mapping the data from the to the file resources, so did you discuss? I mean, did you take a help from anyone else from the medical side, or you choose your own? That guy, this data is mapping to that file resource, or stuff like this.
We have a project team that comprise of doctors, nurses, and different healthcare providers.
Yeah.
So when we show them the FHIR resource that we want to adopt,
Yes.
and then when we go into the code system, and then we discuss with them and whether to accept or not to accept.
Yeah, that's why I'm asking. I mean, that either you decided from your own side that, oh, guy, this data should be mapped to this file resource, because some data is very simple. It's okay. For example, like the patient data.
Right.
But some data is technical. I mean, when we are talking from the computer point of view, so it is extremely difficult for the computer expert to match, because we need them medical expert.
Exactly. Some of the data which is very simple, of course, you can actually suggest, and
Yeah.
very straightforward. But
Yeah.
some of the clinical data is going to be very difficult for you to decide,
because the domain is totally different from the computer. When we are talking from the computer point of view, so the
Right.
medical domain is totally different from the IT expert.
Right.
Yeah.
So what we did, we have a consensus, a group of project team who came from a different background. So in that from that angle, we had a consensus. But what interesting is that Ministry of Health in Malaysia have a special unit called National Informatics Center. So they are the guardians of all different set of data. So we can always refer to them whenever if big decision need to be made.
That's good, sir.
Is there any other questions from the floor? Because I think all the questions in the chat are being answered.
I thank you very much, Dr. Serene and it's very very insightful, and we can see in the a lot of attendance from this webinar. It is the most participant in our webinar. So it's sure that Malaysia is leading on this area. My question, I don't quite sure that have been answered or not. That in the projects, it also Malaysian is also developed the HIS at KKM, which is the hospital information system, right, for the 7 hospitals. So did you use the open air as the information model in developing this hospital information system?
I'll answer that. Bunchai, the HIS at KKM is actually the HIS system that was built for us for many years ago. It is not only for this 7 hospitals. So it's already an existing system that we are just now rolling up, but we really need to update it further to become a cloud-based and so forth, which is going to be done in this project. So the TPC OCHIS, which is the system for the primary care, and the HIS KKM is an existing running system. So for this project, it's just a rollout. But in Malaysia, we also have commercial-based systems that's used in our hospitals, and in private hospitals, also there are many mix of systems. So we are hoping that through this health information exchange is where we can sort of standardize for data exchange. But for the source systems, it can be any systems that is chosen by the facility or by the authority. But for this project, we are choosing the existing HIS at KKM and TPC OCHIS.
And this is the Malaysian grown.
This is our homegrown. Yeah, this is our homegrown. But we also have international based systems like the Cerner systems, the iSoft, and all other systems that is being used in Malaysia.
Who developed these HIS and the clinic?
No, we had a vendor. It was outsourced, but it belongs to Ministry of Health.
Oh, I see.
The source code belongs to Ministry of Health.
Yeah. So the vendor developed, but the owner is kind of the Ministry of Health.
Yes.
Okay. Thank you.
Yes, sir. I have a silly questions here. I posed a question that what type of standard are you using for data exchange here? That was in the first session. I didn't know about that. So someone told me that replied my message that we are using HL7 version 2 for data exchange.
Yeah.
But now here focusing on the FHIR.
Right.
So either they are using just only for data storage FHIR, or I don't know. Actually, I'm confused here. Either you are using the FHIR for data exchange or HL7 version 2. I'm talking about the data exchange.
Okay, maybe I can answer that.
Yes,
moving forward from now on, when we have this electronic health record, or what we call lifetime health record, all the source system, all different HIS and different clinic system will send their payloads to HIE using FHIR, using HL7 FHIR.
Yes.
What I'm referring to currently in the existing hospital information system that currently being used, at a different hospital, when they want to integrate with their subsystem like lab system or radiology system, they use HL7 version 2.x.
Yeah, actually, more than 85% legacy health care system are still using the legacy system HL7 version 2.
Right.
So it is extremely difficult to replace with the FHIR even with the nights. So that's why I'm asking.
Yes, of course, of course. I believe that there is a need to have either regional or national level kind of initiative to get everybody to be involved and support the change from the old version to
the new way. Sir.
Yeah. So you
but
need
difficult,
to have,
sir. The game is difficult. It is not easy.
Yes. We are lucky in the sense that in Malaysia we have got MOH who drive this initiative. With this EMR project, so MOH have decided that look, we are going to go into HL7 FHIR, so everybody will have to just follow that.
Yeah, that's great. The initiative is great. I mean, because most of the people across the globe, particularly in the Western world, they are focusing on the fire.
Yes, yes.
I understand this.
Mhm.
And your initiative here in Malaysia, it is the new one. I'm listening for the first one that someone is working on fire in Malaysia.
Okay.
Yeah, yeah, that is great.
And
I appreciate your work.
Thank you. Thank you.
Thank you so much.
Dr. Fasila and Dr. Aslin and you and Salina, you have to come again because of it seems like we need more Malaysian experience. Dr. Alvin would like to know more on the HIS at KKM and the other. So
ETCOCs, yeah.
yeah,
Maybe
yeah,
another webinar.
yeah, for sure.
Yeah.
I think we reached the time.
Yeah.
Did Dr. Alvin, would you like to say the few words before we finish this session?
Thank you, Dr. Bunchai. Congratulations to Dr. Fazila and the Malaysian team, Dr. Azin. We are very impressed and we look forward to learning more from you. Thank you.
Thank you.
Thank you.
So, yeah, sir, one thing you mentioned that we have a plan for fire training. So do you have any plan for fire training?
Of Alvin, I think.
Oh yeah, yeah.
fire
We
training.
have we have 45 people who will be undergoing live instructor-led training from August 5 to 7. And
Yeah.
we have five people from 5 countries currently undergoing the advanced fire proficiency training. And you should be an AeHIN member and stand by for more trainings. We will be offering more of that soon. So please join the AeHIN mailing list. Thank you.
I already joined, sir. Anyone accept the invitation? Hopefully, I will join. I mean, that training. I'm extremely interested in fire training. That's why.
Okay, thank you.
Mohammed Asad, so you based in what countries?
I'm based in Malaysia.
Oh, I see. So it's a big team in
Ayas,
Malaysia.
sorry, Ayas, you are from?
I'm here from Sunway Monash.
Oh, from Monash. Okay.
Yeah, I'm from Monash University. Yes.
So from university, Buncha. Yeah. Okay.
Oh, CP also used to teach there, right?
Yeah.
I see.
Madam, you are also here in Malaysia? Fazila.
Asking me?
Yeah,
I'm from Ministry of Health. I'm the project director for this project.
Yeah, nice.
She's the boss, Muhammad.
Thank you so much. No, definitely. I need some help because I'm facing difficulty in the fire implementation. That's why I'm asking. So I would be so thankful if you could share your contact detail, email, stuff like this. So if I need any guidance.
Yes, join us, Muhammad. Thank you. Join AeHIN. Thank you.
I already joined you.
Okay.
Thank you.
Thank you so much.
Thank you very much for everyone for joining us. It's very lively and entertaining webinar, and we are looking forward to the more on Malaysia experience on that. So bye and good night.
Thank you, Zarina. Thank you, Azrin and the team. And thank you, everyone. Good night.
Thank you.
Good night.
Thank you, everyone. Good night.
Goodbye.
Thank you.